This program is brought to you by Emory University.
Our speaker this morning, as you can see, is Dr. Arnav. Kumar Arnav is one of our first-year clinical fellows, but a third-year fellow in our clinical investigator track. He did his medical school in India, did his residency at University of Texas, came here, worked with Dr. Samity in his lab, and is a future interventional cardiologist, has already signed and sealed at the Brigham and Women's Hospital in Boston for 2021, so we congratulate him for that. And as you can see, he's going to talk to us about, I think, a little bit about chronic management of coronary disease and shear stress mapping. Arnav.
Thank you for coming, everyone. Thank you, Dr. Wheelings, for giving me the opportunity to present. And the objectives of this talk are, we'll talk about the current state of affairs of management of stable coronary artery disease, role of shear stress mapping in patients with coronary artery disease, and then we'll jump into coupling advanced imaging with computational vascular diagnostics that can help predict future ACS. So stable coronary artery disease management, where do we stand? And as you know, the COURAGE trial enrolled 2,300 patients with stable CAD and divided them into an optical medical therapy group versus a PCI group. The patients enrolled in these trials were required to have a significant coronary artery disease, which was defined as angiographic stenosis more than 70% in at least one epicardial vessel and signs of ischemia on EKG or a stress test. And as you can see, after a median follow-up of nearly 5 years, no differences were found between the PCI and the medical therapy group in terms of combined cardiac outcomes or in terms of death, MI, or hospitalization for ACS. So then came the Barry 2D trial, which had patients with stable CAD and diabetes mellitus, and they were selected if they, again, had at least 50% angiographic stenosis in one of the coronary vessels along with a positive stress test, or more than 70% stenosis along with classical angina. The trial also demonstrated that when compared to medical therapy, a revascularization therapy did not have any differences in terms of survival and other major cardiac outcomes. And then comes the ischemia trial, where patients were selected if they had moderate to severe ischemia on any of the modalities like echo, nuclear, EKG, MRI. Most of them also needed to have a narrowing on their CT, and then they were divided into a conservative arm and an invasive arm. And as you can see, when the conservative and the invasive arms were compared at 5 years, there were no significant differences in terms of combined outcomes of death, MI, hospitalization, heart failure, or all-cause mortality. And most importantly, there were no differences in terms of myocardial infarctions at 5 years. So the question that we all have to ask ourselves is that, are the current strategies to select patients for risk vascularization when we use angiograms, cardiac CT, or ischemia stress testings, are they really choosing or helping us select the patients who are truly vulnerable patients and will have ACS in the future? And this might be a problem because we know since the 1990s when data came out that many MIs actually arise from stenosis, which is less than 50%. So is there an opportunity to identify patients for early intervention? And the biggest problem is that atherosclerotic plaques can differentiate into a stable plaque and become quiescent over time, which cause no symptoms and have minimal risk of causing future ACS. These plaques can be inflamed and then develop into the vulnerable plaque, which has thin cap atheroma, and these patients can develop MI or have future ACS. Or the third variety is when there is progression of atherosclerosis, but they become fibrotic and scarred, and these patients develop obstructive coronary artery disease over time, and these patients have angina, but they do not develop ACS. And we think that local factors such as shear stress can mediate this differentiation of plaque. So predicting future ACS, what do we know? What works? And the Atheroma IVA study had 581 patients with ACS and stable angina, and they underwent coronary angiography and IVAS. And remember, these studies that we are talking about, they did IVAS and coronary angiography and IVAS on the vessels which did not have PCI. And the primary outcome for these studies are non-culprit MACE, which is defined as mortality, ACS, or unplanned revascularization at 1 year. And if you see the classification of plaque, pay attention to this TICFA, because this is thin cap fibroatheroma, and you can see that the necrotic core is almost encroaching upon the lumen. And that is one of the high-risk plaque features defined by IVAS. So in this study, they used VH IVAS, and they differentiated plaques into all these morphological types. And they found that when they created a model which included thin cap fibroatheroma, plaque burden more than 70%, and MLA less than 4 millimeters square, these patients and these lesions had the highest risk of MACE during follow-up. Next is the Prospect trial, which enrolled 697 patients who underwent PCI for ACS. These patients again underwent baseline IVAS, and patients were followed for MACE originating from the non-treated vessels. Interestingly, they found that most non-culprit events responsible for future events arose from mild angiographic stenosis at baseline. And lesion characteristics that were associated with MACE, again, were plaque burden, more than 70%, thin cap fibroatheroma, and minimal lumen area, less than 4 millimeters square. And again, when they combined the high-risk plaque features on IVAS, that was TICFA, high plaque burden, and MLA less than 4 millimeters square, these patients were these lesions had the highest risk of MACE during follow-up. NIRS, that's another modality, and 203 patients with ACS or stable angina underwent near-infrared spectroscopy of non-culprit vessels. The authors measured lipid core burden index, and the primary outcome was, again, 1 year combined endpoint of mortality, ACS stroke, and unplanned coronary revascularization. In this chemograph, you can see this, there are 3 patients, and the patient C has this large area of yellow region that represents high probability of lipid core. And they divided the patients into high lipid core burden and lower lipid core burden, and the patients who had higher LCBI demonstrated greater incidence of MACE and cardiovascular events during the 1-year follow-up period. Now, the problem with all these studies is that the positive predictive value of all these modalities were quite modest to determine future ACS. Now, going from invasive to non-invasive modalities, the ROMICA 2 trial enrolled 1,000 patients with chest pain, a clinical suspicion for ACS, and a cardiovascular risk factor. And then high-risk plaque features were detected by cardiac CTA, and the hypothesis of this study was that if we identify high-risk plaque features on cardiac CT, that will help us improve the diagnostic certainty of ACS in the emergency room. And as you can see, the high-risk plaque features that they used were positive remodeling, low attenuation plaque, napkin ring sign, and spotty calcification, along with severe stenosis defined as more than 50% plaque burden. And all of these features were associated with risk of ACS. Now, another trial enrolled 3,158 patients with suspected or known coronary artery disease, and they followed these patients for fatal and non-fatal ACS for a median period of 3.9 years, and they found that patients who had high-risk plaque features on cardiac CT had higher rates of events compared with patients without high-risk plaque features. And also, patients who had severe stenosis on cardiac CTA also demonstrated higher event rate than those without during the follow-up period. Now, even with the cardiac CT, the positive predictive value was around 15% to identify future ACS. Hence, there is a need to combine imaging modalities with local hemodynamic markers of plaque vulnerability to better identify patients who will develop future ACS. So what is the role of coronary shear stress in patients with coronary artery disease? Wall shear stress is the tangential stress resulting from the friction between blood flow and the endothelial surface of the vessel wall. As you can see in this diagram, for us to determine wall shear stress, you need blood flow, you need blood viscosity, you need the vasculature. And wall shear stress can be seen quite commonly in nature. If you see a river with bends, you will see that perhaps there is slow flowing water currents in the inner curve, and there is high degree of silt deposition there. And the fast going outer currents, there is mostly erosion on the banks of the river on the outer bends. Types of shear stress, it's similar in the coronary vasculature, where there is undisturbed and laminar flow in many areas, and this is thought to be vascular protective. While especially in bifurcation zones and some of the bends of the coronary vasculature, we can see low and oscillatory disturbed laminar flow, which are thought to be pro-inflammatory and atherogenic. So what did we do? We hypothesized that low wall shear stress might be associated with endothelial dysfunction, and that we know that endothelial dysfunction occurs early in development of atherosclerosis. So we enrolled 44 patients with non-obstructive coronary artery disease, and all of these patients underwent coronary reactivity testing with intracoronary acetylcholine infusion. We used Q-angio, and we used Q-angio to perform 3D geometry reconstructions on co-registered pre- and post-acetylcholine cineangiograms. And then these resulting pre- and post-acetylcholine 3D models were discretized into longitudinal segments of 0.5 millimeter length. Endothelial function was defined by the percentage change in diameter, and it was calculated for each 0.5 mm segments. Pay attention to the definition of severe endothelial dysfunction. Basically, we define severe endothelial dysfunction when there will be a vasoconstrictive response to acetylcholine, which will be more than 10%. And low shear stress was defined as less than 1 Pascal. So as you can see, the areas of the coronary segments which had low wall shear stress had predominantly vasoconstrictive response to acetylcholine. As you can see in this graph, the segments which had low shear stress, as much as 71% of these segments with low shear stress demonstrated severe endothelial dysfunction. We found that low shear stress was independently associated with endothelial dysfunction. In this nonlinear graph, we can see that the probability of endothelial dysfunction increases to about 95% in the coronary segments that demonstrate low shear stress. Coronary segments with low shear stress often co-localize with segments demonstrating endothelial dysfunction. And hence, our group, along with a group from Mayo Clinic and the Brigham and Women, we proposed that the pathway to atherosclerosis progression might be mediated by low shear stress, especially in patients with obstructive coronary artery disease. Now, biologically, on a local plaque level, low shear stress induces endothelial cells to become apoptotic and dysfunctional. This causes infiltration of LDL and lipid oxidation, local inflammation, enhanced platelet activation. All these activities attract monocytes that differentiate into macrophages. And hence, low shear stress might cause progression of atherosclerosis. Our group enrolled 20 patients with non-obstructive coronary artery disease who underwent baseline and 6-month intravascular ultrasound examination. And we found that patients who had low shear stress had higher plaque area, higher necrotic core, and higher fibrotic area at follow-up. The prediction study enrolled more than 500 patients with ACS who underwent 3-vessel intravascular ultrasound at baseline and at 6 to 10 months of follow-up. And the authors found that segments with low shear stress demonstrated a greater change in lumen area, resulting in a lower lumen area at follow-up when compared to other shear zones which were not low. Low wall shear stress segments also demonstrated a greater change in plaque burden at follow-up, indicating more plaque progression during the follow-up period. The prediction study also found that low baseline shear stress and large plaque burden at baseline were associated with worsening of clinically relevant luminal obstruction requiring PCI. The prospect study patients were taken again, and there was a post hoc analysis done from that. Now in prospect, again, there were 697 patients with ACS who underwent IVUS at baseline and at follow-up. And then high-risk anatomy by IVUS was defined as more than 2 of these, which is plaque burden of more than 70%, MLA less than 4, and thin cap fibroatheroma. And they found that lesions with low shear stress at baseline were associated with non-culprit MACE during follow-up. And indeed, when they made a model which included both low shear stress and high-risk anatomy, these lesions had the highest risk of non-culprit MACE during follow-up. And these results were followed when they did a patient-level analysis as well. Some authors took the MGH OCT registry, and they performed baseline and 6-month OCT on about 25 coronary artery disease, and they found that coronary segments with persistent low shear stress demonstrated a numerically higher prevalence of lipid-rich core, lipid-rich plaque during follow-up, significantly higher prevalence of thin cap fibroatheroma during follow-up, lower fibrous cap thickness during follow-up, but similar lipid arc during follow-up period. So in conclusion, we can say that in coronary vessels with non-obstructive coronary artery disease, low shear stress is associated with endothelial dysfunction, low shear stress is associated with plaque progression, and low shear stress is associated with future non-culprit MACE. So, ladies and gentlemen, that's when we started proposing that coupling advanced imaging with computational fluid dynamics can probably help us predict the future ACS. And we took the FAME2 data, and as you might recall that in FAME2, patients with stable coronary artery disease were selected based on FFR less than 0.80, and a segment of these patients underwent PCI and medical therapy, and the other group of patients, they only underwent medical therapy, only got medical therapy. And as you know, the FFR-guided PCI strategy had a lower MACE rate when compared to medical therapy alone. However, a closer look at this data will show us that the primary outcome is driven by urgent revascularization rates, which were much lower in the FFR group of patients. And hence, there was a need for a better marker of regional plaque hemodynamics for proper risk stratification of patients with stable coronary artery disease. Now, what does high shear stress do? Especially in obstructive coronary artery disease patient, high shear stress stimulates endothelial cells to produce plasmin and transforming growth factors. It stimulates macrophages to release MMPs, which degrade collagen and matrix. And it stimulates macrophages to induce apoptosis of smooth muscle cells. Hence, in all, high shear stress decreases fibrous cap stability. And Dr. Samedi and our group here has shown that zones with high shear stress can cause progression of necrotic core and greater development of expansive remodeling. Zones which have high shear stress often demonstrate more vulnerable plaque physiology with lesser cap thickness. And in another study, Dr. Lee and his group showed that patients who had culprit lesions had higher shear stress, and high shear stress was associated with CT-derived adverse plaque characteristics such as low attenuation plaque, positive remodeling, napkin ring sign, and spotty calcification. Hence, In atherosclerotic plaques, high shear stress decreases fibrous cap stability. High shear stress is associated with vulnerable plaque transformation, and thin cap fibroatheromas areas of plaque rupture co-localize within regions of high shear stress. And culprit lesions demonstrate high shear stress compared to non-culprit lesions. And in many studies, we have found that proximal segments of the plaque are particularly vulnerable to plaque rupture. And hence, we hypothesize that in patients with with low FFR, high shear stress in the proximal segments of atherosclerotic lesions predict MI. This is the lesion segmentation that we did. As you can see, we calculated shear stress on over a whole lesion and also divided the lesions into proximal, middle, and distal third. And we found that shear stress calculated across the whole lesion predicted MI at 3 years. However, the best predictive value was actually shear stress calculated in the proximal zones of the lesion. And hence, we found that in patients with stable coronary artery disease who were FFR positive, had a higher event rate or a higher MI rate when they had proximal shear stress, which was higher than 4.7 Pascal. And we found that when we combined wall shear stress, that is proximal shear stress, to FFR, the combined model had an improved prediction ability to identify patients who will have ACS at 3 years. And this is a representative case. You can see that both these lesions have FFR of 0.71, but the proximal shear stress in patient A is high at 7.12 Pascal. This patient had an MI at about during the follow-up period, whereas the patient B with a shear stress value of 1.43 Pascal did not have an MI during follow-up period, although the FFR values were same in both. So in conclusion, in patients with stable angina and FFR less than 0.80, high shear stress in the proximal segments of lesions predicted MI and had an incremental prognostic value over FFR. Now, what is axial plaque stress? This is another important hemodynamic force, and it is the axial component of traction acting on the plaque. The Emerald study with Dr. Lee, who's the PI here, they enrolled 72 patients who had available CCTA, which was done 1 to 24 months before developing an ACS, and they underwent computational vascular diagnostic. They identified convention parameters like diameter, stenosis, lesion length. They also identified the high-risk plaque features on cardiac CT that we talked about. But importantly, they also calculated FFR-CT, delta FFR-CT, which is basically difference of FFR across the lesion, shear stress, and also axial plaque stress. And they found that delta FFR-CT, diameter stenosis, and shear stress were 3 of the strongest predictors of ACS, even when the plaques were identified using cardiac CT. And indeed, a model that they created with diameter stenosis and adverse plaque characteristics and adverse hemodynamic characteristics, which include shear stress and APS, this combined model had the best prediction value as indicated by the best area under the curve for predicting ACS. And hence, when they did the analysis at the lesion level, the proportion of culprit lesion was significantly higher in lesions which had both adverse plaque characteristics and adverse hemodynamic characteristics, which were high shear stress, high APS, etc. And lesions with both adverse plaque characteristics and adverse hemodynamic characteristics showed significantly higher risk of ACS compared with lesions who had either one of them or none of them. And in this representative patient, they are showing that the LAD lesion here has both adverse plaque characteristics, which might be high risk plaque features, and then adverse hemodynamic characteristic. And this patient developed MI during follow-up, whereas this RCL lesion had adverse plaque characteristics, but not high shear, not high APS, and these patients did not develop ACS during follow-up period. Plaque structural stress. This Plaque structural stress is calculated through finite element analysis and represent multiple variables such as plaque geometry, tissue material properties, and hemodynamic forces. This high shear stress can also be a principal mechanism of plaque rupture, resulting in thrombosis and sudden ischemic clinical events. Some of the authors took the prospect study again. Now remember that prospect study had 697 patients and underwent VH-IVUS. And they found that higher PSS, higher plaque structural stress, and higher heterogeneity of plaque structural stress was associated with increased risk of future MES in patients who had thin cap fibroatheroma as identified by VH-IVUS. Now, shear stress mapping can also help improve hemodynamic profiles of future stents. Now, in the evaluation of stent platforms, we thought that bioresorbable scaffolds, where the whole scaffold gets absorbed in the vasculature, we thought that was the pinnacle of our stent technology. These stents were thought to will perform better because they will have a better hemodynamic profile and a low thrombogenic milieu. And this will decrease the in-scaffold new atherosclerosis, device thrombosis, target vessel failure rates. So to our surprise, when the ABSORB BVS trial showed that higher device thrombosis and target lesion failure rates compared to Xience at 1 year, and which was marched out to 3 years as well. As we discussed, we have shown that low shear stress might be associated with coronary artery disease. And there is an impact of the stent strut design on flow patterns. As you can see, in non-streamlined struts, there can be large areas of low oscillatory shear stress, while streamlined struts have smaller low shear zones. These phenomena also depend on strut sizes, where the larger strut size stents can cause larger low shear stress zones. As you can see, it has been shown that these areas of low shear stress can cause platelet activation and a procoagulant, prothrombotic region around the stent. Whereas more streamlined struts, these phenomenon is not seen. Scaffold thickness has an impact on stent thrombosis as well. As you know, the Xience is only 81 micromillimeter, whereas BVS is 157 micromillimeter. And we have recently seen in a large meta-analysis that strut size, when it is more than 120 micromillimeter, these struts can cause thrombosis during follow-up. And low shear stress leads to higher new intimal thickness after a year. Some small studies have shown that BVS segments have low shear stress zones. And when the shear stress, the segments which have low shear stress have high amount of new intimal thickness during follow-up period. And hence, it is postulated that this low shear stress can lead to higher degree of target vessel failure during follow-up period. We took the ABSORB imaging study and we conducted IVUS analysis and CFD, computational fluid dynamics, on 77 patients who had BVS and 36 patients who got Xience. This is just the post-processing where we calculated shear stress across the whole device and also in the proximal, middle, distal, outer, and inner curvature of the device. And we found that patients who received BVS were almost 5 times more likely to demonstrate low shear stress. And this case example, you can see that this area which got BVS demonstrated low shear stress throughout, whereas the Xience vasculature demonstrated more physiologic shear stress. And we found that as much as 22% who received the BVS stents demonstrated low shear stress across the whole stented area, while only 6% in the Xience group demonstrated low shear stress. And then we are also working on other micro CFDs, where basically you can actually see each strut and do shear stress mapping on it. and we are hoping with OCT-based analysis, we'll be able to find more reasons, more ways how we can improve stent designs. And hence, in conclusion, ladies and gentlemen, we can say that low shear stress is associated with endothelial dysfunction and plaque progression in patients with non-obstructive coronary artery disease. Among patients with obstructive coronary artery disease, high coronary shear stress may help identify vulnerable plaques. And coupling advanced imaging with computational vascular diagnostics can help identify patients at risk of ACS who will benefit from early coronary interventions. I want to thank Dr. Samedi, who is my mentor, and I worked with him for the last 2.5 years. Dr. Lee, who helped me with the slides. Many other fellows, Dr. McDaniel, who also helped take the field ahead, and many fellows, future and present, who have worked in Dr. Samedi's lab and in this area. And I'm ready for questions.
Arnav, that was great. It's real tour de force. It's nice that you started out with a nice clinical angle, but you know, as you said, even this sort of work has clinical ramifications and is really on the cutting edge. So let me ask you a question, because you did obviously a spectacular job working in the lab, and we're very proud that you're going to take this over to the Brigham, where Peter Stone is, and I know your passion is to kind of move this field more in the structural field as well, where there's a huge opportunity. So tell me for a minute how you view this field of hemodynamics moving into the structural space, both in terms of coronary evaluation of patients with aortic stenosis, but also in terms of implanting TAVRs and potentially mitral clips and stuff. So what's your vision for that?
Yeah, that's a great question, and it's such an exciting field. Of course, Dr. Samedi knows that we are, both of us are involved in this, working and taking this to the coronary artery disease and the TAVR field. So the biggest issue, like one of the biggest issues that we find right now is that coronary artery disease assessment in patients who have severe aortic stenosis. And we think there is a huge opportunity for taking this work there. As you all know, when we do coronary artery disease assessment using FFR and IFR, there is a big variability because of the high EDP, and data has shown that in 15% of the cases, the FFR is not very reliable to measure coronary artery disease severity. And we think that these patients who are, sorry?
In patients with
in severe aortic stenosis. Now, these patients are all getting coronaries, are all getting TAVR CTs, and there might be an opportunity for us to tap in that, where we do a good structural valvular investigation, but also we use the coronary CT part of it, where we calculate all the things that we saw here, the high-risk plaque features using coronary CT with the low attenuation plaque, with the napkin ring, and all those things, but also calculate CT-FFR, CT Shear, CT APS, because if there is one thing from this talk that we want to emphasize on is that no one risk stratification strategy is enough. Especially in cardiac CT, we can get everything from them, like the diameter stenosis as well. Now, going to the TAVR work, there is definitely a role for shear stress modeling when there is to predict which patients will have who are at high risk of thrombosis. And there is a good amount of work that has been done from our friends at Georgia Tech in this field as well.
Great. Let me ask another question. We have Alessandro Veneziani in the audience, who many of you know is our collaborator, who really, he and Don Giddens have been instrumental in the science, math, and engineering side of all this work. So maybe I can ask Alessandro to make a comment on this idea that mathematics that you've been so passionate about plays a role in clinical medicine and translation of that. And maybe you can say just a few words generally about where you view that, because I know you've worked with vascular surgeons, with Bob Taylor, you've worked with us and others, but it's really sort of harnessing all the wonderful and rapid changes in mathematics and bringing it to our clinical questions. So if you want to put your speaker on, I think you have to push that button.
Okay. So yeah, thank you. Thanks for the presentation. Was really so good. I could follow almost everything. So yeah. So I think that with mathematical tools we can improve. We can help understanding or predicting, because our mathematical models have this nature. We can do simulations as well as you look weather forecasting. We can try to anticipate what may happen, and this is what we are trying to do, for instance, with stent. But we have many problems and uncertainties. So we need coefficients, we need boundary conditions, and it's always difficult to have the right number. And this means that we need to live with some uncertainties, and what we are trying to do is to quantify how reliable we may be with our computation. So you can say, okay, this is reliable, no, this is not, I need to look at in a different way at our problems. But yes, we may help working with you, Habib, and Arnav. We can try to cover anticipating problems, and take numbers on things that you cannot measure. In particular, washer stress is a great example, because it's not something you can measure easily. You can sometimes, but it's from images, but it's never reliable enough as we can do with our computations. And we are evolving. So please, in everything you do, consider sometimes you are used to mathematicians as statisticians, basically, but not only statisticians. We may help in computational modeling, adding many aspects that you could not even imagine. We can, like with stent. I'm finalizing a paper now, and it was really difficult. It's 10 years of work now on stents, just to understand how to convert the images into something reliable for our computation. But I think that we can help the design of next generation bioabsorbable stents with topology optimization, which is the real challenge here.
I have to say, like we're all busy clinicians in the room, we're researchers, et cetera, but one of the things I found unbelievably rewarding is to hang out with people like Alessandro and just kind of ask clinical questions, and it's amazing what they can do with modeling things that are totally uncertain. Think about placing a stent in a calcified artery, and think about all that forces that exist on the vessel wall, the hemodynamic forces. There's just so much uncertainty. There's no way clinically on an angiogram or even with OCT or IVUS you can measure that. But in years and years of discussions, weekly meetings, et cetera, we get to understand what tools they need. They get to understand our questions. And it turns out there are not a lot of places in the world, I want to say, where mathematicians and clinicians and engineers roll up their sleeves and work together. And that's part of the reason that people like Arnav and, everyone, Olivia and Parm, all these guys have really enjoyed this really rich environment. Maybe if I can just, a couple of other things. Maybe I can ask Dr. Lee, Jumyoung Lee, who's here, and he's a visiting scholar from Korea. Arnav just presented a couple of his papers, but Dr. Lee has really had a major impact in the guidelines and done a lot of incredible work in physiology and imaging. And we're just so delighted that he's with us for a year here. So Jumyoung, could you make a comment about, where are we right now with, and Arnav did a spectacular job reviewing it, but in your estimation, in terms of, let's say you have a lesion with a 50% LAD, they come in with some atypical chest pain, they have an FFR that's, say, negative on an angiogram. And let's say now that's your uncle or your dad, right? Or it's yourself if you're my age. So in that scenario, what can you do at this moment? Obviously, there are all the biomarkers that Dr. Kayumi is working on, but what can you do from assessing the plaque? And Arnav may want to comment on this as well, to tell that patient what their risk of having a heart attack is in 3 years.
Yeah, that's a great question. Actually, the current evidence is generated from randomized trials. Our medical treatment might be the best treatment of choice, but I think that is because we don't use or we don't have the many other core variables which can impact on patient prognosis. For example, the Shear stress or biomechanical force, Plaque characteristics. Even although we use those core variables in research, but in our clinical practice, we still cannot integrate those core variables in assessing patient risk. So I think that might be because that's simply too complicated in our busy outpatient clinic. So in future, maybe some artificial intelligence algorithm, after we input all those information in that algorithm, maybe that algorithm will determine the patient prognosis and what will be the best treatment strategy, early intervention or lifestyle modification, or even strong biomechanical modification using some drug. So I think we have some open future. So we have a lot of things to do. And maybe Arnav nicely presented about all these positive features of biomechanical force, but we have to think about the limitation of the biomechanical force. As you well know, the Shear stress largely influenced by region definition. And that means we have high measurement variability. So I want to ask a question to Arnav. So what do you think about doing the CFD and complicated region definition and getting the biomechanical force versus artificial intelligence or deep learning process using image only? So what's your first?
Dr. Samity knows this. I'm a very big, I'm very suspicious of AI, always. Because I have actually worked on this field a little, and AI is pattern recognition, and it is as good as your worst observer. So when you take, and of course, Dr. Min and all these great people have done a lot of CT work based on AI, and you really have to go in and see who is developing, like how are we coming up with this AI? Who are the observers? Are they super trained in CT? I hope they are. And then that AI is good. To your second point, of course, and Dr. Samdi's point, this slide shows that about 70% of MIs arise from patients who had less than 50% angiographic stenosis. Now, talking about shear stress, and when you said that the value of shear stress or the magnitude of shear stress is low, and I always talk, when I describe shear stress to our medical students, I say that when you have a paraplegic patient and they have their elbow which they can't move, and you'll see after a while there is tissue decomposition there. That's how I feel about shear stress. It's a small magnitude force which is acting on the plaque for a long time and causing plaque transformation. And you want to know whether that plaque will be transformed early. You don't want to know it that the patient is going to have a STEMI tomorrow. We want to know it 3 years back. And that's what we showed in our study. Again, this is not perfect, but also, as I showed in the first few slides with EKG, nuclear stress, and all these other modalities, I think a single test strategy is not sufficient. because where is the data that these prevent MI or prevent ACS in future ACS? So that's why I think there is a huge opportunity in the CT field where you can calculate diameter stenosis, you can calculate plaque hemodynamics, and as you know, Scott and all these studies have shown that with CT you can do good work.
Any questions, Steve?
So Arnav, when looking at this, what about control of LDL in these groups?
Yeah.
Do we say that we had the same degree of LDL control in these groups? Were they all on ACE inhibitors, or how do you answer that question?
Yeah, there is a study which Olivia Hung and Dr. Samedy did, and they followed shear stress for 6 months, and they gave atorvastatin on these patients. And I think there was a numerical decrease in all the plaque burden and the shear stress values and things like that. Definitely, we need more studies on this field. There is a study from the Cleveland Clinic where they also gave the patients for a year of statin, and they demonstrated with repeat IVUS that the plaque burden decreased by about 10%. I think Dr. Neeson was the person who did that.
But I think that, I guess the important point, Steve, that you're making is, look, we've got a whole bunch of known risk factors, including diabetes, LDL, other inflammation. And so am I reading you correctly? Your question is do these biomechanical factors have additional value over and above the known risk factors?
Yeah, I suppose they do. Say, in these groups, like you had, how many patients did you have that had an acute MI from plaque rupture in this group? I know you had one because you talked about it. That was a rare event, or?
If you go to your
FAME?
high wall shear stress, yeah.
You did have one.
No, all of them did.
Yeah,
go over that, and the FAME2, let me just go. All the patients in that study had documented vessel-related myocardial infarction at 3-year follow-up. And actually, I think we spent a lot of time, because as you know, many of the endpoints are major adverse cardiac events, and you don't know if that's unstable angina related to another plaque. You don't know if it's something else. But for that particular study, that's why the numbers went down so much, because so Arnav, let me let you talk about this.
Okay. So, the FAME2, we took the cohort which was managed medically. All of them had at least one vessel less than 0.80. And these were 441 patients. Of these patients, 441, 8% had vessel-related MI. So we wanted to make sure the FFR that we interrogated at baseline, that vessel was the vessel which is causing MI in the future. And of these, so for computational fluid dynamics, we need the vessel to be interrogated in 2 angles using angiogram, and 5 of them did not have that. So that dropped us to 29. And these 29 patients were then risk matched with a non-MI group, control group, which was 29. So we used a propensity risk match to make sure that the demographics, clinical, even angiographic variables were equal in both groups of patients.
So as you think about arteries that have lesions in them that have plaque characteristics that are not good, and as you think about these plaques as they rupture and provoke the clotting system and likely to clot the whole vessel, do you think that every plaque that ruptures results in occlusion of the vessel, or what is your concept of that? The reason I ask you that is because Mike Gravanis years ago told me, he says, we see ruptured plaques all the time in the coronaries in the pathology room. And many, more times than not, they don't result in thrombosis of the vessel. Is that a concept that you have, Arnav, or not? You know, in my mind, I say,
Tough to
oh my
answer.
gosh, they're gonna rupture a plaque. Next thing you know, they're gonna occlude the vessel. Next thing you know, they got a STEMI. So conceptually, do you imagine that we can rupture plaques sometimes and they can heal? They obviously can, but.
Yeah, Dr. Samity will be better to answer this question, but I think probably not all plaque ruptures cause vessel obstruction.
Right, I think that's probably right.
But one of the substrates that we know causes is one of the sure shot markers of ACS is thin cap fibroatheroma.
Yes.
And there are many definitions for that. The OCT definition is the best. But even in one of the studies, we showed that VHIVs can also make us identify thin cap fibroatheroma. And we have seen that high shear stress zones co-localize with thin cap fibroatheromas.
Yeah, but I agree, and anyone else feel free to chime in, but I mean, to me, you're pointing out all the complexities of this disease, right? We know from several autopsy studies, actually as well as OCT studies, that if you examine patients with coronary disease, although some plaques will go and rupture and occlude, other plaques will actually rupture and spontaneously heal, and then re-rupture. So you almost, if you can image them or see them under pathology, you almost have like an archaeologic map of recurrent rupture and healing that happens. And actually, as you point out, the pathologists, both Dr. Gorvanis and also Renu Vermani, have taught us that. So the question is to your point, why do some vessels rupture and then the thrombotic cascade takes over, the vessel closes, they have an infarction, they have an arrhythmia, and bam, they die. And another vessel, maybe in the same patient, might rupture and spontaneously resolve itself with lysis and healing and so forth. And the patient may or may not experience it as a clinical syndrome. And that's the complexity of what we're dealing with. And obviously, we know that the biomechanics, which we're trying to dig into, is only one of the pathways of a very, very complex systemic problem. You know, I think we don't have a lot of, maybe we do have vascular biologists, Aziz and others who've done this in the past, but it's a complex process, right? Inflammation, prothrombosis, oxidation, all this stuff, as well as mental stress. So I think it's complicated. And the challenge we have is currently stress testing and stress echo, the way we do it now, is very good at, you know, kind of picking up some disease, right? But all the studies show us, whether it's COURAGE or Barry 2D or now the large ischemia study, that if you revascularize those vessels, you're not helping people live longer, that's for sure. So can we start getting into these intricacies of all, and there's no way a single group's gonna do all of that, right? You've got to come at it multiple fronts. Our group is pretty passionate just because we live in the cath lab of leveraging imaging with engineering and mathematics and understanding the biomechanical component, but there are all these other complexities. And I think it'll be a while. And that's why the work, I thought your slides about positive predictive value were fabulous, you know, because, you know, although you can show that you're pretty good at predicting the odd patient, you know, can you develop a clinical tool? And that was my question to you as well, Jum Young, where somebody has a 50% LAD, it's you, right? This is serious, it's your LAD, it's 50%. How good is your current test in 2020 at telling me whether that vessel is going to close and cause an infarction at 3 years? That's what you want to know, because currently it's not causing ischemia. So should you be doing, and what should you be doing about it? Should you putting, and actually Stan Sherman asked a great question via text. He says, well, what medical therapies do you guys have to alter adverse hemodynamic conditions, such as high wall shear stress or load? Does anyone know of any medical or mechanical therapies in 2020 that we have? And those are the sort of questions we should be asking. You know, what about PCSK9s? What about the new diabetics agents? What about if you...
Cholesterol.
What about cilostazol? You know, so there are all these questions. And also the problem with stents is that they themselves, you replace one disease with another one, And the newer stents are really, really good, but they're not perfect. So as the stents get better, you can then select lesions that only are at moderate risk and maybe stent them if your stents have very little risk. But we know that stents have risk, so you've got to get that balance right. What do you think?
Yeah,
Finish it up with your career, man.
with my career. Well, I think just as everybody said, the positive predictive value of one test is not enough. And I think we need to use a strategy where we combine multiple strategies in one test to help us truly identify patients at risk of future ACS.
The preceding program is copyrighted by Emory University.